Thanks a lot for all of our listeners right now who are joining us. It's a wonderful pleasure to be here and to be welcoming Professor Berit Schneider-Stickler. Berit has been a wonderful friend and colleague for many years. Um, I always enjoy listening to her presentations and to her lectures. She has been doing wonderful work in teaching others and teaching colleagues about EMG and about using botulinum toxin. In addition to the fact that she is leading a wonderful group in Vienna in Austria. First, I'm really happy to be here listening to you. I know how wonderful your presentations are, and I'm really looking forward to enjoy listening to them. Unfortunately, we didn't meet uh, since the start of the corona pandemic, but I'm really looking forward uh, today to listen to your lecture uh, by distance, and in the future to listen to it lively in a place that hopefully we will be meeting in the next few months. The title of today's webinar by the UEP is the application of botulinum toxin in Phoniatrics and Laryngology. Berit, uh, please go ahead.
I really would like to thank you for this very nice introduction of my person. And I really would like to thank you that you give us a chance to come together even here as a webinar, all in front of a computer. But I'm really happy to join this family of the European phoniatricians. And I'm really a bit disappointed that we cannot meet personally this October in Antalya. So I really would like to support even your idea to meet here in webinars. And you did a great job to bring us together here with the different seminars in the past. The first one given by Professor Nauka, then Professor Rubin. And so I feel very proud to join this series of webinars. So thank you very much. And it was your recommendation to talk about the application of botulinum toxin in laryngology. And I'm really, really happy to talk about this topic. And you're right, I like this topic very much. We do the botulinum toxin injection for many years. And I think as everybody in our family is affected by the COVID pandemic, also our work changed a lot the last few months. It was so easy to work before March 2020. Then we started to get the first equipment with some nose-mouth coverings, so very simple stuff. And meanwhile, the personal protective equipment is the most important issue in our field, in the laryngology. And even if you would like to continue with the botulinum toxin treatment, we need to consider the protection of our staff and of our patients. And so everything got quite complicated, but nevertheless, we are happy enough that we can continue with our work, especially as the botulinum toxin is very famous. And sometimes I'm a bit jealous because the Botox already could enter the title page of newspapers. Who will reach this? But botulinum toxin reached to be on the title page. Yeah. And how you can see, it is very famous in medicine, in cosmetics, and it has so many disciplines where you can use the botulinum toxin, so it became a really famous drug in medicine. I would like to introduce here a update review from 2014. It's a group around Mandavia from London, and you can see here a very good systematic approach where and how you can use the botulinum toxin in different fields of the otorhinolaryngology, the blepharospasm or mandibular dystonia, spasmodic dysphonia, dysphagia, stuttering, I go to the right side, hemifacial spasm and Frey syndrome, and so on. So you see that we have so many fields to use the botulinum toxin. If you summarize it, then you can treat problems with the exocrine gland function, like in the Frey syndrome. You can treat the voice disorders, facial palsy, facial scars, dysphagia, tinnitus, and many, many different dystonic problems. I would like to introduce here a patient with a quite severe jaw opening problem. He tried to say just an R. And I'm quite sure if anybody sees this video, everybody has an idea how to treat, what could be the reason, is it a neurologic problem? So we could discuss these very complicated cases, I think, for hours, because these are really difficult cases. But if we point out the main aspects of the botulinum toxin application, what is the effect, why do we use it in our fields, then we have to know that the botulinum toxin inhibits the release of the acetylcholine at the neuromuscular junction and in cholinergic sympathetic and parasympathetic neurons. If you inject the botulinum toxin into a muscle, especially in an overactive muscle, you can weaken the muscle. And if you use it in salivary glands or any other glands, then you can control the hypersecretion by, if they are supplied by cholinergic neurons. So we use the botulinum toxin in different aspects of focal dystonia. And we use here the effect of weakening the muscles, and sometimes you of course can have a side effect of even weakening the adjacent muscles. If you go further, what is botulinum toxin? Most of you know this already. Botulinum toxin is one of the most poisonous biological substances which we know, and it is produced by the bacterium Clostridium botulinum. Meanwhile, sorry, this was the wrong direction. Meanwhile, we know that the botulinum toxin inhibits the acetylcholine neurotransmitter at the neuromuscular junction. It blocks the transmission. And by blocking these transmitter synapses, the muscle becomes clinically weaker, and depending on the doses, it can even become atrophic. But we all know that this is just a temporary effect. Sometimes we appreciate just to have a temporary effect because we have a sprouting of the nerve terminals and the formation of new synaptic contacts after approximately 3 months, latest after 6 months. So if the patient asks how long will be the effect of the treatment, then usually we can say we have an effect of 3 to 6 months after injection. For me, it is very important to understand where we put the botulinum toxin, even to control the effect and also to control the side effects. When we use it, then we block the alpha motor neurons at the neuromuscular junction. But we have to have in mind that we also can have an effect on the gamma neurons, which may alter reflex over activities. So far, we know that we have 8 to 9 different, depending on the literature. We have different serotypes of the botulinum toxin. We use for the human being the type A and the type B. If we go into the commercially available products, then we have 3 products containing the botulinum toxin A and 1 product with botulinum toxin B, and everybody knows that we have the Botox, the Dysport, and the Xeomin. All these 3 substances have their advantages, their disadvantages. I would like to admit that I favor the Xeomin the last few years because the Xeomin has a slightly different manufacturing process. That means it is a kind of naked injectable with no any other additives. And advantage is that we have a lower risk of getting resistance against the botulinum toxin A serotype compared to Botox and to Dysport. And the Xeomin, you don't need to put into the refrigerator. You can just have it on your desk or somewhere where it is easier to get it from. The price of these three different product types is quite similar. As I already mentioned in the beginning, if we take the list from the review where we can use the botulinum toxin in otorhinolaryngology, then we have three main groups for laryngology. These are the voice disorders, voice tremor, spasmodic dysphonia, contact granuloma, even sometimes hyperfunctional voice disorders with no response to logopedic treatment. Then we treat the dysphagic patients if you have dysfunctioning of the upper esophageal sphincter, for instance. And we also use it for some other neuromuscular conditions with breathing difficulties. Here we use it in the unilateral vocal cord paralysis in case of synkinetic innervation, and sometimes we also use it in bilateral vocal cord paralysis. The approach for the botulinum toxin application can be either percutaneous, transcutaneous with needle electrodes, or we can do it with bronchoscopic approach where you can even insert a long needle for the injection of the botulinum toxin. Here, just also depending on your favorite position, you can put the patient either in a supine position or you leave the patient in the upright position to do the needle injection, here in this case, if you want to perform a transcutaneous approach. For preparation of the patient, we use local anesthetics, either spray or skin infiltration or even superficial cotton swab instruments. In times of the COVID pandemic, we should avoid the spray and we should avoid any sneezing, coughing, even in the perspective of the self-protection. Usually we use the prilocaine hydrochloride or the lidocaine or the tetracaine for local anesthesia. Here you see the injection technique, and here for a indirect approach, we do the anesthesia with spray and with cotton sticks. In case that you combine it with the laryngeal EMG examination, then of course you have to prepare the patient with the equipment of superficial electrodes here for creating a connection to earth, and then a superficial electrode not directly close to the larynx, but close to the larynx. And we usually record also the breathing maneuver of the patient by putting such a thoracic belt around the chest. So for the needles, we have to consider the concentric needles, the monopolar needles, and also maybe you know the single fiber. When we do the botulinum toxin injection with EMG, we prefer the monopolar concentric needle electrodes. Here you can register the laryngeal EMG, and if you have found the right spot to put and to inject the botulinum toxin, then you have already the cannula and the solution in the needle, so you can do the application if you found the right spot. If you take the approaches how to reach the endolaryngeal structures, I would like to introduce here the pictures from Sulika from 2010. You can go with your needle, with your cannula, through the thyroid, transthyroidal. You can come from above if you insert above the superior notch of the thyroid cartilage, or what we prefer, we go transcricothyroidal here through the membrane to reach the thyroarytenoid muscle, or even to reach even the PCA from the approach from anterior. If you have such a throat, then everything seems to be very easy. You see the upper thyroid notch, the Adam's apple, very easily for orientation. In such a slim throat, slim neck, you can palpate the cricoid. You can even palpate the lower edge of the thyroid. So it's quite simple to find here the entrance for your needle, for your cannula. So here it is very simple to find the anterior approach, but of course you can also choose the lateral approach for the injection techniques. If you want to do it with the EMG, I recommend the paper by Fabian Volk and his working group from 2012. He did a great job to give us instructions how to do the EMG, how to reach the muscles, how to do EMG from the CT, from the TA, PCL, LCA. So this is a really very, very recommendable guideline for performing laryngeal electromyography. And I really recommend to take a larynx from an autopsy just to understand the anatomy once again. Even if you are a very experienced laryngologist, sometimes it's good to remember the anatomy, to remember the dimensions, because you learn how you should palpate the neck and how you should palpate the larynx just by having in mind the anatomy. Because if you just come from the front, from the anterior part of the neck, and you go straight through the larynx, you do not really know exactly where you will enter the larynx, where you will enter, in this case, the PCA. And I'm always a bit surprised to see, even if I go straight through the larynx, that in this case, I entered just the upper portion of the PCA, although I wanted to enter the middle portion. So it is very, very important to have a good idea about the three-dimensional anatomy of the larynx. If you come a bit higher, then it could be that you enter the interarytenoid muscle, and of course you get completely misleading information on the muscle activity. Why it is important? Because we started with doing botulinum toxin injection percutaneously also into the PCA in case of a synkinetic reinnervation. And here we would like to be in a safe way to reach the PCA instead of any other cricopharyngeal or interarytenoid muscle. Once again, we should have in mind that sometimes you need to go a bit downwards depending on the palpation of the larynx to reach the right portion of the muscles. What are the criteria for even the needle insertion? We usually do not the botulinum toxin into a silent muscle. So we can expect insertion potentials if we enter the muscle. And of course, we can consider the muscle unit activity potentials during the agonistic volational activity. Here, for instance, a EMG from the thyroarytenoid muscle. It is not a normal EMG. You see there's always a little activity even in rest, and you have to check the activity in phonation and in breathing to evaluate the activity.
Berit, one of the things that is coming to my mind is that, do you have sound there because we're not hearing it?
This is what I expected. Why don't you have the sound?
I have the answer.
Yeah. Okay.
You will do just one thing, which is very small. You will stop sharing the screen.
I stopped sharing the screen.
And then share the screen again. And when you open it, you will find that on the left side above the options, there is
computer tone frag. I see it. Yes, yes, yes.
Yeah.
Can we try again? Oh,
So
was it
you did check it right now.
Moment, now I need a password. I'm very sorry.
That's fine. But did you check it when you're yeah, good. So now
it needs a password.
Actually, now we see it very well. Can you? Now we hear it. Wonderful.
I'm so happy. Thank you. Thank you.
Konnte man durch die Nase aufziehen, die Luft. Nochmal. Nochmal. Nicht so fest, nur so. Nochmal.
So this is how we do electromyography, and the interpretation of the EMG findings, of course, lead us to the decision for the treatment. So if we go into some diagnosis, I would like to start with the voice tremor. The voice tremor is a problem of the elderly. I'm sorry. Usually the people or the patients are older than 60 or 70. And if you go into the literature, you find a percentage of approximately 4% of population developing the voice tremor. I would like to give you Yeah, this is a quite severe situation of a patient. And of course, this is not just simply a voice tremor. Even the voice tremor can be a bit more complex. This is another patient, a singer, a former singer.
Immer zufrieden, wie's immer sie fügt.
He was performing even almost until his 80th birthday, and he was very, very unhappy with this voice. And this, of course, is even a challenge for us, for the laryngologist. And so we need to know some background about voice tremor. Of course, everybody knows that voice tremor is a kind of modulation of the voice signal. You can differentiate between a frequency modulation or amplitude modulation. And you find this also in a vibrato, but the vibrato you can modulate and you can volitionally influence the vibrato rate, the expressiveness, but the tremor is a pathological voice production involuntarily, and the patient has no influence on the frequency and amplitude of this voice signal. We did this in an acoustic manner just to show you what do I mean. If you sing an R without any vibrato, you see a quite straight fundamental frequency line. If you do it with an artistic vibrato, you see a quite regular modulation of, here in this case, of the fundamental frequency. And if you have a patient with the voice tremor, and if this patient sings an R, you see this quite irregular, very big amplitude modulation of the fundamental frequency. But the voice tremor can have different influences. It can be influenced by the thyroid muscles. It can be influenced developed by thyroarytenoid muscle, by sternothyroid muscles, and by cricothyroid muscles in different percentages. And usually you have a mixture of all of these different muscle activities. I really like this scale or scoring system of evaluation of voice tremor because it is very important to differentiate if it is palatal. Is it the base of the tongue? Do you see any pharyngeal wall movement? Is it just a larynx voice tremor, or is it even shaking in a supraglottic area? So this is very important to evaluate, and the working group here recommend to do the severity evaluation by a 4-point scale, and this gives you here even an impression of the scoring system of the severity of the voice tremor. Why it is important? Because the voice tremor can be treated either by voice therapy, if it's just a very mild degree. You can try different pharmacotherapy concepts, propranolol, primidone, but we have here very often side effects of the medication. I always say if you have a medication with an effect, then usually you also have a side effect, and many patients cannot live with the side effects. So at the moment, we consider even the botulinum toxin for a chemodenervation of the muscle overactivity, and we reach, if we have very, very clear voice tremor patients, where you can decide where to put the botulinum toxin in, then you can reach quite stable results for up to 6 to 9 months, for a longer period than just 3 months. This is a patient I would like to show where we did the injection with the EMG, palpation of the larynx, and if you find the thyrocricoid membrane, then you can insert the needle. Then you have to control via the EMG signal.
Und
And as soon as you are in the right place by EMG control, you inject the botulinum toxin. And
so, das war's.
And usually we do it bilaterally, and as you can see, it takes usually only a few minutes to inject the botulinum toxin in the voice tremor patient. If you go to the next diagnosis, then I would like to go further with the spasmodic dysphonia. Spasmodic dysphonia was described, or has been described for a long time as a psychogenic disorder. Meanwhile, it is reclassified as a group of focal dystonia. So far, we assume disordered central motor processing, but so far we don't know the real reason for the spasmodic dysphonia yet. We can differentiate the adduction spasmodic dysphonia, the abduction spasmodic dysphonia, and seldomly you can also find mixed spasmodic dysphonia. The majority of patients with spasmodic dysphonia will present adduction spasmodic dysphonia. This is very impressive if you hear the voice very pressed, very without harmonic vibration of the vocal folds. So this is really obvious by hearing just diagnosis making. And we do in these patients usually also the flexible laryngoscopy to see the speaking voice, to hear and to see the speaking voice. Sometimes if you do it only with the rigid endoscopy and you have an sung E, then of course it can be that the patient can sing because it's another function, but he cannot speak. And that's why we prefer the flexible endoscopy in spasmodic patients. I hope that the sound is working. It is a very pressed voice without any regular vibration. And here the spasmodic dysphonia was a symptom after an ischemic stroke. And we are treating these patients already for many, many years with quite good success with the botulinum toxin into the thyroid muscle. Another patient, so this is the same patient after 1 week, I'm very sorry. And it is very hard to find the right doses, even if we just use 1 or 2 units, mouse units of Xeomin, and you hear a kind of breathiness in the voice. Yeah, so the respiratory mobility is quite okay, but after 1 week, the voice is a bit weak, breathy, after injection of 2.5 mouse units Xeomin, and this was 4 weeks after injection.
Und mein
Interestingly, she developed now a kind of tremor,
Nochmal
but the
im Kopf
spasmodic
anhalten.
component
Zunge
disappeared.
rüberkommen. Das ist zu viel? So.
Yeah, so at the beginning of the laryngoscopy after botulinum toxin injection, I always have a long period of just watching the breathing to see if we have symmetric movement in the vocal folds, because I'm always a bit nervous about the side effects. But here it was really just for a short period of time, quite weak voice and breathiness. Another Another topic, the unilateral vocal fold paralysis. And here I would like to introduce patients with synkinetic renervation. And if you listen to the voice, you hear quite good voice quality. These patients, like also the other one, it was thyroid surgery with intraoperative nerval reanastomosis. All our colleagues, otolaryngologists, would be happy to see that the patient has a very good closure, and nobody would expect that these patients suffer from airway problems, shortness of breath, sometimes attacks like laryngospasm. So these patients were told there cannot be a breathing difficulty because one side is working properly, the glottis area is wide enough without any obstruction. So, and we found out in these patients after performing laryngeal EMG a spasmodic dysphonia, not spasmodic, I'm so very sorry, synkinetic renervation, what means we have here the problem of a wrong innervation. And I would like to bring into your mind the classification by Professor Cromley of the laryngeal synkinetic renervation. Professor Cromley introduced 4 types of synkinesis. The favorable type 1, here we have a quite good position of the paralyzed vocal fold with quite normal phonatory quality and no airway problems. There's no need for therapy. But we have also 3 unfavorable types. And if you look here at this table, you see that airway difficulties can be present in this type 3 of the laryngeal synkinetic renervation. And here we also use the botulinum toxin for treating the problems of the patient. So once again, a patient with laryngeal EMG and a synkinetic renervation. We inserted the needle here into the TA muscle, thyroarytenoid muscle.
Und durch die Nase kräftig aufziehen.
The sniffing maneuver.
Und nochmal. Durch die Nase aufziehen.
Usually you should not have activity in the TA muscle during the sniffing. Meanwhile, we learned from the literature and from other colleagues that you can have approximately a third of activity of the volitional activity even in the sniffing maneuver, but you should not have a more dense signal during sniffing compared then to the phonatory signal. If you have almost the same density of the motor neuron of the activities, then you have to consider that you might have a synkinetic renervation. And I introduced at the beginning that we perform the botulinum toxin also in bilateral vocal fold paralysis. Usually we are confronted with severe breathing difficulties in patients with bilateral vocal fold paralysis if the vocal folds are fixated near the midline, paramedial positioning. But if the vocal folds are not that close during respiration, then we can consider other problems. And we have, meanwhile, several patients even with synkinetic renervation in bilateral vocal cord paralysis, which we treat with botulinum toxin because the patients denied to undergo tracheostomy, or they denied any other chordotomy, or they also already received a glottal widening by laser surgery. After visit in Rouen and joining a course with Professor Marie, we also started with renervation techniques. So, but this is a very, very young development in our department. So we are more experienced with the botulinum toxin injection in few patients, if applicable. So, and the botulinum toxin injection in bilateral vocal folds has been first described by Jean-Paul Marie in 1998. Usually we do it in the adductor muscles, like shown here by Ekbo et al. And we also have the problem that it is only temporary, so we need to find a solution, but maybe it is a way for a permanent solution later on in synkinetic renervation with the laryngeal pacemaker. So, Professor Geneid, dear Ahmed, you mentioned that I should stay short so we can even discuss some questions, and this is good. So I just would like to introduce how we do the injection in these patients. Of course, you can do it transcutaneously, even into the posterior muscle, but usually we do it in the transnasal bronchoscopic approach, and I just would like to introduce here a video from a patient. So you see the needle, the cannula here.
Wollen Sie einmal schlucken? Genau so.
My colleague who is doing the bronchoscopy is Dr. Leonhardt, Matthias Leonhardt. He is really experienced in guiding the bronchoscope to the right place. Now we entered the goal where we wanted to inject, and I do then the injection. You see it is quite easy to do if the patient is compliant. And another situation, another patient with bilateral vocal cord paralysis and synkinetic renervation, how I can convince you what does it mean. I would like to show you a intraoperative video from superficial electrical stimulation with the Osipka finder. You see the posterior part of the glottis, and we insert the Osipka finder to the right side, and you see the left side movement, the closing. And if we think that this might be synkinetic renervation in bilateral vocal fold paralysis, then we go into the operation room and do the electrical stimulation to understand better what is going on here. And we usually also inject the botulinum toxin intraoperatively, but later on, if you do a repetition of this treatment, again, the bronchoscopic intervention. You can do the local anesthesia via the bronchoscope. This is the lidocaine solution, what you saw here. Yeah, we do the local anesthesia by dropping down.
Das Licht ein bisschen zu.
And sometimes it is not so easy to guide the bronchoscope, and if you reach the spot where to inject, then you take the needle and you inject. Yeah, so this is what we do in our outpatient's office then, without complications so far. And the same, what I would like to show here is that we do this in recurrent contact or vocal process granuloma patients. We all sometimes suffer from the situation that we do surgery of the vocal process granuloma and you see the recurrence after a few weeks, after a few months. Sometimes colleagues do another surgery to remove the granuloma and it comes back. So the patient is quite disappointed. We are disappointed, and meanwhile we combine here the intervention with botulinum toxin injection. It has been already published by Damrose 2008, so that we have to consider that it is maybe the problem of vocal abuse and mechanical alteration, mechanical damage in the cartilaginous part of the vocal fold. What might be the reason for development of the process granuloma? And here, if voice rest, voice therapy, RD reflux, pharmacotherapy, any other intralesional cortisone injections might not have the success of avoiding any other recurrence, then we also weaken the muscles of closing mechanism by botulinum toxin injections. Here, patient with such a situation again, the same procedure, local anesthesia. And as soon as you can enter even the endolarynx, you can go. And then you can inject into the muscle. The bronchoscopic approach is only possible if you have two colleagues. One is guiding bronchoscope, the other one is responsible for the needle guiding and for doing the injection. And as soon as the needle enters or enters the larynx, then we have to be very careful not to do any other unwished damage of the mucosa. So I already mentioned that we do also the Botox injection into upper esophageal sphincter dysfunction. In this patient, we first performed the EMG from the lateral approach to examine the upper esophageal sphincter. We already had information about the dysfunction by video fluoroscopy, swallowing test, and so we decided to inject here the botulinum toxin via EMG control from the more lateral approach. Here you have to turn the larynx to the side so that you can enter the side and that you can reach the upper esophageal sphincter. In this patient, we were quite safe because it was a tracheostomy patient, because you can, of course, if you do it in the wrong muscle, you can cause a vocal fold palsy. But in this case, the patient was tracheostomized, so we had no problems with the stability of the airway. So, and to come already to an end, what is my take-home message for botulinum toxin application in laryngology? Botulinum toxin is a safe treatment option in selected voice disorders, in some neuromuscular diseases, and in dysphagia due to dysfunction of the upper esophageal sphincter. It is a well-tolerated in-office-based procedure. You should use the LEMG if you want to do it percutaneously. And what is very, very important, to always choose the correct dose to prevent undesirable side effects. And with this, I would like to thank all of you, all the listeners in front of the computers to joining our webinar on the application of the botulinum toxin in laryngology. I really wish that everybody of you will stay healthy in even this very difficult times. And I really, really hope that we don't get a second wave and that we can meet next year in Antalya, because I would like to see the sea.
Yes.
Many thanks, Ahmed.
I'm sure that really this was an excellent presentation. I'm also looking to see the sea, hopefully next year in Antalya, and hopefully by then the situation will be much better with the pandemic. Actually, we got a number of questions, and also I have a number of questions here on my right side. Why don't we take the questions first, if you, and also for the participants and for the audience, if you have questions, then just write them in the question and answers or the chat.
Good. I found a list of two questions in my system. Is it right? One question is, what is the doses? I can talk about the Xeomin. Yeah. We use usually for injection of the TA muscle, thyroid muscle, we take 1.5 to maximum 3 mouse units of Xeomin. If I do a PCA in synkinetic renovation, then up to 5 mouse units. Usually I don't need to go higher. For the injection into the upper esophageal sphincter, we use approximately 20 to 25 mouse units of Xeomin. This is approximately dose for Xeomin, botulinum toxin, which we use.
This is wonderful. We have also another question asking about if you have experience in doing injections in the false vocal folds.
We did it few times. The same, approximately 2.5 to 3.5 mouse units. Here we go a bit higher. If we go with the dose higher in the true vocal folds, then the side effects of breathiness can be longer than 4 weeks, and this makes the patient quite unhappy. So we try to go very low if we go in the true vocal folds. If we go into the false vocal folds, we go a bit higher with the Xeomin.
What kind of, do you use that for patients with spasmodic dysphonia or
with very severe hyperfunctional dysphonia? We had patients with with phonation at the level of the false vocal folds, where we never could see the vocal folds. In very severe hyperfunctional situations, then we also inject into the false vocal folds.
This is exactly what I'm doing, and usually they have either a history of atrophy in the vocal folds, or they have sometimes. I have a couple of patients who had normal adductor spasmodic dysphonia, and then it changed. It started not to react to Botox in the vocal folds, and checking them, you find that the false vocal folds are closing very tightly.
You're completely right. You are totally right. The longer we dealing with this patient group with neurogenic problems, we learned that the symptoms can change over time. You start with hyperfunction, then you get a spasmodic, then you get kind of tremor. So they are all close together. It is not really easy to differentiate between these diagnoses. You always have to have in mind that you can have even all the 3 aspects together. Totally right.
We have another question, and do you also combine voice therapy for your patients receiving Botox?
What kind of question?
Do you also combine voice therapy for the patients?
Yes, of course. Yeah. Of course, we always do. I would say our department is the last option for patients, where our colleagues send the patients to after failure of voice therapy, after failure of any other treatment. So our patients always have experiences with voice therapy before we decide to do any botulinum toxin injection.
Wonderful. Now we had questions from Turkey, from Mexico. We have also a couple of questions from Egypt and Croatia. What are the specifications of the injection needle you use while injecting via the bronchoscope?
You mean the name of the needle? Oh, the name of this needle, I don't know, because this depends on the type of the bronchoscope. You need a bronchoscope where you have a channel where you can insert this needle. Our needle is 1.5 meters long. It should be very small. The needle itself, the diameter of the needle. For the transcutaneous approach, we usually use, I have no computer system, whatever. We use 24, 25 gauge. So maybe the size of the bronchoscopic needle should be similar.
That's what I agree to. The needles that I'm using via the channel fibroscope is actually, it was made for the gastroenterology.
Exactly.
And this is the main reason that it was made. And we are using it for the larynx, which is an interesting, but it's fine because this is it's the same airway and the same gastric air.
That's right, Ahmed. The only problem, it is quite long.
Yeah.
And if you use a long needle, you lose a lot of material.
Yes.
Use it also for injection with hyaluronic acid. And here you need 2 packages, one for the needle and one for the patient.
Yes.
And this is sometimes a bit disappointing. Yeah, if you consider the price.
Yes, it's sometimes it is very disappointing. And also I had a situation in which 2 of the needles, one was sometime when you take the needle out and in a couple of times, it sometimes it will not
blocks.
work. Yeah.
Yes, I have the same experience. It blocks and you cannot do any movement. You cannot do the needle out or in. And this is really frustrating. I thought I'm the only one with this bad experience.
No, you're not the only one.
Thank you for sharing this. Thank you.
I contacted, the first time when I had this, I was really, like, is this happening to me? And right now, I can assure you that the company knows that they are having this problem. So,
really?
Yes.
Oh, Ahmed, I will contact them as well.
Yes.
Because it's so frustrating. You filled in the Xeomin or hyaluronic acid, whatever it is. You want to do the injection, and the needle doesn't come out.
Yeah.
So you have to do,
And sometimes it comes out, but there is a resistance, so nothing is coming out of it.
Thank you for mentioning.
And now we have the next question, which is in case of vocal granuloma, vocal contact granuloma, is one application sufficient in your opinion of Botox?
Okay, you ask for my experiences or for the experience in the literature? I started with doing the botulinum toxin injection short time ago because of the frustrating results with all the other therapy strategies with voicing, with voice rest, stop any loud talking, to even equip patients with hearing aids if they have the hearing loss. So I did almost everything to avoid any recurrency of the granuloma. And I inserted the botulinum toxin in a few patients, and I'm really, really surprised. I did it with 1 injection without a new recurrence of the granuloma. So far, I needed only 1 application. But maybe, depending on the dose, you need maybe 2 later on.
Yes. And one other question is that, actually you answered it already, it is coming from Munich. And do contact the granuloma come after botulinum toxin disappears? It seems that so far, so good.
Usually I combine surgery with application of botulinum toxin, because when I see when I saw these patients I'm talking about, the granuloma was quite big. and they couldn't even close the vocal folds for voicing. So I decided to even do the surgery to remove the granuloma, and I combined it with the botulinum toxin injection.
I
And
totally
with this,
agree.
yeah, and with this strategy, I'm quite happy at the moment. Yeah, if you have a very little contact granuloma, then maybe only botulinum toxin injection might be sufficient.
Exactly. And do you have another question is coming about the portable EMG? I guess the one who asked the question means the EMG devices that gives you the sound but not the wave.
You mean that you have a portable EMG where you just can hear, if you have experiences with the EMG signal, then you can rely on the voice sound, on the EMG sound. We have a very little EMG device ourselves, and in few cases, I use this portable EMG too, just relying on the sound. If you get experience how the muscle activity sounds in EMG, then you can rely even on the sound without having the waveform on the screen. Yes, you can rely on.
Yes. I also have another question that when I'm doing the injection, one of the things that always come to my mind is that you cannot be 100% sure if you are, sometimes you cannot be 100% sure if you are in the thyroarytenoid or in the lateral cricoarytenoid. And sometimes...
Yeah, this is right. What I learned in these patients, there is a little aspect what you might consider. The ACA complex starts usually with a prephonatory burst of activity, as a very, very dense activity with high amplitude before the phonation. And it is weak during the phonation. If you are in the TA, usually you don't have this prephonatory burst, and you have a quite stable, dense signal in the phonation. And so I try to differentiate, am I closer in the TA or am I closer to the ACA? But you're right, there is no 100% reliability that you reach the ACA or the TA. I always would say we have the complex of TA and ACA.
Well, do you find, sometimes do you find some kind of reactions that you hear in the patient voices that you think, okay, maybe I went in the ALCA last time?
With the botulinum toxin?
Yeah.
We started a few weeks ago. That's a very short history. We started to do electrical stimulation of the ACA. Just to learn, is it different? And I cannot differentiate the voice sound by injecting into the TA or ACA. No, I cannot differentiate yet.
Yes.
But what we try to learn with the EMG and even with ultrasound, to learn the anatomy to be safer by injection, and to insert either the TA or the ACA just by the proportion, how deep you insert, the angle, the width, and so on. This is what we try to learn even with ultrasound guided examination and with EMG.
Yes, yes. There is another question that is that came out, which is how often the spasmodic dysphonia patients need re-injection?
Usually twice a year. Yeah, so we do it in our spasmodic dysphonic patients usually every 6 months. Voice tremor sometimes a bit longer. They wait longer until they come back for another follow-up, but spasmodic dysphonia shortest 4 to 5 months and sometimes 9 months.
I have to admit that this is a little bit different from what maybe we are sometimes injecting less amounts. We are doing Botox every second week. So
really?
Yeah, yeah, we have a full day every second week, and we have a situation in which we have certain patients who do not tolerate the beginning or the first phase in which you have oppressive voice in the beginning. And
Exactly.
these patients, they go for the option that they come every second month. Some of them even come every, like 1.5 months, and or second months
Okay.
actually. And they get very, very, very small amounts. So they are ridiculously small amounts, like
Yeah, this is
0.5 units of Botox. And
okay.
but
Okay.
but this is probably because of the fact that we have been doing this every second week. Otherwise, I remember in the old days we used to have it once a month, and at that
Yeah.
time, we didn't have such small units or amounts of Botox
Okay.
being
Okay.
injected.
Now, I have few patients where I tried to inject lower doses, less than 1 milli, well, 0.1. And they complained that the effect was not that strong. So they were disappointed. So they tolerate the 1 to 2 week period of being breathy more than a less effect of the botulinum toxin. So that's why maybe we can wait longer for re-injection.
This is we have more questions for the anterior approach for the BCA. How do you prevent cough when the needle bath through the airway?
You cannot prevent. The only what you can do is the best preparation, even by injecting some of the local anesthetics into the trachea. We started to give patients, when we have in mind to do this maneuver, we started to give the patients even codeine drops before the examination or before the injection, so 20, 30 minutes before our maneuver. This helps a lot. And then, of course, you have to go with the patient. You cannot avoid coughing. If the patient needs to cough, you have to take out the needle. And then you start again. When you do the transcutaneous approach from anterior, you can go either through the tissue in the subglottic tissue of the vocal fold to enter the cricoid, the pellet, the plate of the cricoid, which you have to drill through. Or you can enter the air column to go straight through the air column. My experience is if you enter the air column, the patient has to cough. That's why I try to go through the vocal fold to reach the cricoid in the posterior part, to drill through, and then to enter the PCA. This causes less coughing reflex than just going straight through the air column.
Yeah, but my understanding is that you find it also possible to, of course, some coming would come, but you can inject lidocaine, for example, through.
You can do, yeah.
And
this we do for preparation.
Yes,
if we
exactly.
know that it might be cause any discomfort,
yeah,
then we offer more preparation for the patient.
Yes, and that's true. That in the end, the patient is going to cough in any way. Because, for example, when you are injecting the lidocaine as an anesthetic,
but then it's okay.
It's I have a question that came to my mind.
Yeah.
Actually, two of them, and the first one is that what you had a very nice table in which you showed one of the researches and about synchronases and about when to use the Botox, and one word drew my attention, which was tonic adduction.
Yeah.
Do you remember what was meant by this?
My screen is shut off. Can you see my presentation? Then I might go back to this slide. No.
No, but it just came to my mind that and now we see the presentation.
You see the presentation. I just want to. I think this table needs. There is it.
Yes.
This needs to I'm in a discussion with colleagues from Gera and from Vienna and with Professor Crumley himself to even reevaluate these types of synkinetic reinnervation. But what we see sometimes that the vocal fold has no atrophy, has no bowing, and is really very, very tense, straight in midline.
Mm.
So it is completely adducted to midline. And these patients, where have you read this? Vocal fold are lateralized. This is abduction. So tonic means you don't have atrophy of the TA muscle. You have no bowing. Yeah, so we see from the shape of the vocal fold that there is activity in the TA because there is no denervation and there is a tension in the muscle. This is meant by tonic. I think
And
Professor
I'm really
Crumley,
happy, yeah, I'm really happy that you explained this, because one of the things that I usually get questions about from the residents is that in sometimes, or not in sometimes, but in some literature, there has been assumed wrongly that if you have a paralyzed vocal fold, that it is not having a tonus. And the tonus can always be there in a paralyzed vocal fold.
Can be, exactly.
Exactly. And this is good that you
Exactly.
explain it.
And
So
for me, meanwhile, if you see a paralyzed vocal fold without any respiratory movement, but you see that there is tension, there is a tonicity in the vocal fold, you can be sure that you will find a synkinesis.
Exactly.
This is not a denervation.
Yes, and this is very important thing, because one of the things that we have also to explain to the listeners, especially the young ones, that when we talk about the synkinesis, the nerve became attached, but the cables that are running inside, they are not running to the right direction. So you have afferent, you have adductor going to the abductor and abductor going to the adductor. So things are going, there is tonus, that's what it means, that it is adducted or abducted. There is tonicity, so it is not like totally bowed and curved. So there is tonicity, which is one of the most important things for the production of voice.
Exactly. And here I learned so much from my colleagues in the last few years by doing the EMG, because the EMG understanding changed my stroboscopic evaluation ability. So I really evaluate the laryngostroboscopic findings in a different way, since I know about these reinnervation potentials. Even the movement in the arytenoid cartilage. Sometimes we saw patients with failure after thyroplasty in unilateral vocal fold paralysis, and the voice became worse after a few months, and I saw a abduction of the paralyzed vocal fold during phonation. And I learned that this is because of synkinesis. And now I understand why Professor Marie recommend, even if you do the thyroplasty, consider that the synkinesis is in the majority of the patients after months. And that's why he recommends to overcome these unfavorable types of synkinesis by doing non-selective reinnervation techniques. So I learned a lot in the last few years about these problems with the synkinesis. And it's interesting what you can see if you learned to look, to observe, and to interpret in a different way. It's not just evaluating the respiratory position. It is little tiny movement somewhere, and it's really interesting to interpret.
It is a total, I guess one day we should have a webinar about the synkinesis by itself.
Wonderful. This would be great.
Because it's I mean, like a whole different world, and what is happening and how you can affect it, and how it affects what you're seeing when you see a little bit of movement, but you are not sure. Is this helpful in any way? I'm really happy that we had this this wonderful presentation and wonderful discussion with you. As I said in the beginning, it's always really nice to hear your presentation, to listen to your knowledge, I'm very thankful. We already crossed the 1 hour that we planned to have because of the wonderful company that we have, you and the listeners. And I'm again thankful for you, Berit, for the wonderful presentation. It has been a pleasure to listen to you. And I'm really hoping that one day we will meet, hopefully soon, maybe by the sea in Antalya or even before that.
Please, before that. Thank you so much. And take care.
Thank you. And thanks for all of the friends who are and colleagues who joined us. I'm very happy that you have been listening to the presentation, and we stay in contact by email from the UEP when you get our monthly newsletter and information. Thanks a lot, and have a wonderful evening. Thank you.